Dear all, good afternoon. This is Maria Tzalonikou. I come from Athens, Greece, and I am here tonight on behalf of ESSR webinars to host this last ESSR webinar of the season. Now, before starting on with tonight's presentation, I would like to make a small announcement. Next year's webinar schedule will be announced at mid-September. Webinars will be held the second Monday of the month, but for March. For March, there will be special announcement. Attendance, as you all know, is free, and registrations next year will be starting for each webinar the first of the month. Now, tonight, it is my honor and my privilege to introduce you Dr. Victor Cassar-Pullicino, coming from Oswestry, UK. Dr. Pullicino is well known, not only among ESSR members. Well, some of the reasons he has been really well known is the beauty of basic knowledge during the last TCRs. He has been the soul of this organization, and he is the soul of the organization of Spinal meetings in Oswestry for several years now. Now, today's webinar is going to focus on signs of spinal injury. As it usually happens, tonight's presentation will start with a case presentation that is going to be done by Dr. Timothy Wu, who is a fellow in Dr. Pullicino's department. Dr. Wu, please.
Hello, my name is Dr. Timothy Wu, and I'm one of the clinical fellows at Robert Jones Agnes Hunt Hospital in Oswestry, UK, and I'm going to present a case to you about trauma in a fused spine. Now, this is the case that you will have received with your teaser material, so I'll quickly go back through the case details. Here we have a 75-year-old male patient who has a known previous history of spondylosis from his GP and also of a left-sided stroke, and he has a dense right hemiplegia. However, despite this, he was mobilizing well with sticks at home with no additional help. He was not an anticoagulant despite the stroke, and he presented at the District General Hospital after having a fall against a cupboard door from standing height. When he presented at the Accident and Emergency Department, he was conscious with GCS of 15. He had some tenderness over the lower cervical or upper thoracic region, and it was noted that he had a severe kyphosis. His neurological examination was normal for him, so that he had no power or sensation in his right upper limb and markedly reduced sensation and power in the right lower limb, with only some power present in L2 and L4 myotomes. And the left side was entirely normal, as was the PR examination. At the District General Hospital, a CT scan of the cervicothoracic spine was performed, and this demonstrates, as you can see on the bony windows at the top, a completely fused cervicothoracic spine, fusion of most of the facet articulations, ossification of the longitudinal ligaments, and also across several of the thoracic discs. Associated severe kyphosis, and additionally disruption of the ossified ALL and the anterior cortex of the C7 vertebral body, as well as the C6 spinous process. Now, the MRI was performed the next day at the specialist hospital here at Robert Jones, and this is the limit of what you will have received with your teaser material. Hello, can you hear me again?
Yes.
Sorry, we lost the audio there for a second.
Okay.
So on the MRI scan, I'll give you a few seconds to check your answers. And here you can see a large posterior epidural collection. which is extending from C5 to T3 levels with high T1 and T2 signal, seen on the left and the right, in keeping with an epidural hematoma. The cord is displaced anterolaterally and is compressed, but there was no cord contusion noted, although as you can see, the images acquired were of quite low quality due to the patient's kyphosis. Notably, on the stir sequence in the top right, the actual bony injury showed very subtle edema. The patient was given the option of conservative or surgical management, and he opted for surgery and underwent posterior stabilization from C4 to T2. At the time of the operation, the neurology was entirely stable, and intraoperatively it remained stable, and as such, it was discussed that the epidural hematoma was not to be decompressed. He had an uneventful postoperative course and was discharged home, and at 6 weeks review, he was mobilizing on one stick, and at 6 months, he had reached near baseline mobility, and he was discharged for follow-up. A few learning points from this case was that patients can present with a complication of trauma to a fused spine, but without a prior diagnosis of fusion, such as ankylosing spondylitis. And this isn't just ankylosing spondylitis that can cause partial or complete spinal fusion. A similarly stiff spine can occur from processes such as DISH or even degenerative changes. A combination of inflexibility and osteopenia in these patients predisposes them to unstable three-column injuries, and on the CT in this case, this was indicated by the presence of a C6 spinous process fracture, showing that this was a through-and-through injury. And the CT should be scrutinized very closely if no obvious fracture is detected on first pass. In ankylosing spondylitis especially, epidural hematomas are not uncommon, thought to be due to extra friability of the venous plexus in these patients. Although both MRI and CT scanning can be challenging in these patients because of their kyphosis, plain radiograph is of very little use, and advanced imaging is always required to exclude fracture or serious injury. I'll pass you back to Dr. Pullicino now, who will do the remainder of the talk.
Thank you very much, Tim. That very nicely sets the scene for me, and the topic I'll be discussing are subtle and manifest radiological signs of spinal injury. In my hospital, we have 2 wards dedicated for spinal trauma. There's an acute ward that admits about 120 new patients per year, and a chronic ward that manages their complications. Obviously, this evening, we'll only be concentrating on the signs in acute trauma. I want you to spend just a few seconds looking at the picture in front of you. And I have called this the last snapshot. This is what we need to do every time we image an individual with suspected blunt trauma. And in this case, we are concentrating on the spine. In essence, we are looking at the last snapshot indicating trauma, meaning we will never see what happened at the moment of impact. So if I told you that this is a snow scene, and these are footprints beautifully and equally separated, indicating the prints made by a small rodent, possibly a mouse, who went out in search of food in the morning. And then the thing that you notice is that you no longer see any more footprints beyond this point. So something catastrophic has happened at this point, disturbing the snow scene. And then if you just radiate upwards from this point of disturbance, you will see beautifully the outlines of the wings of a bird, indicating there are feathers. So this indicates a bird of prey that also went out for his breakfast and had what went out for a breakfast originally. So we've worked this out by doing 2 things. We've seen with our eyes, but then very importantly, you need to see with your brain, and you work out, therefore, what happened at the moment of impact. And you need experience and you need intuition as well as information to reach the right conclusion and diagnosis. The imaging approach to spinal trauma, whether you use plain films, CT or MRI, has to go through a number of sequences. Firstly, of course, our job is to say if there's an injury, and if we identify an injury, we need, very importantly, to identify its extent, and very importantly, we look at a pattern of injury, because it's these injury patterns that help us in getting a complete diagnosis. If the patient has neurological deficit, we have to use MR to identify what the cause of the neurodeficit is, and particularly if it's reversible or otherwise. In doing so, we look for bone fragments in the canal. This is a contentious issue in terms of how to manage them, and I will concentrate on these specifically in my talk. And then, very importantly, please remember that patients with one spinal injury, not uncommonly, have other injuries. By play films, the incidence is between 18 to 20%. By MRI, it's over 50%. So there are three principles that I'm going to introduce you to in your approach. The first principle is just have a simple outlook. I say what I see. I think all you need to do is just say what you see, first to yourself, then to someone who comes and asks for the consultation, and then put that in your report. And how do you do this? You do it by looking at the outlines of the vertebrae, if they're deformed, if they have moved in relation to the one above and below, i.e. displacement, if there's disruption of the outlines, and if there has been movement which has widened or narrowed the spaces between the pedicles, spinous processes, facet joints, or disc space. You have to have a consistent approach, and the one I use is using a discovertible column, meaning two vertebrae and the disc at one point, i.e. looking at the motion unit or motion segment there, and I look at it meticulously by looking at the anterior column, the middle column, and then the posterior column. And when I've satisfied I've done my job, I then work my way upwards and downwards, doing the same by looking at motion segments in succession. And if you do this, you then move to principle number 2, which means that you need to describe them. The first thing you do in your description is that you cone and phone in, particularly at the level of injury. You need to hone in at the most obvious level. Always starts with the one that shows the biggest degree of disruption. And then you move on to the contiguous levels and the non-contiguous levels. That, of course, is in the field of view in the imaging that has been used. Please identify carefully and clearly all the osteo and osteoligamentous structures that you feel have anatomically been disrupted. And if on MRI you identify damage to neurostructures, then you need to identify these as well. One of the most often asked questions is, should you in your report classify the spinal trauma? Is it necessary? And in my view, you should not. And the reason why you shouldn't is for two simple reasons. Firstly, there are many classifications. This indicates that none of them work. More importantly, the classifications are really very, very wide in their spectrum. And the likelihood of having low inter-observer differences is very low. So it's very important, therefore, that you just concentrate on identifying all the pathological structures based on the anatomy that have been disrupted and leave the classification to someone else, which gives me to the second reason that the classification should be used by the surgeon or physician managing that patient. By all means, be involved in helping them classify it, but don't classify it yourself in isolation. And now brings us to the third principle, which is the last principle, which is the most important part, which is the recognition of patterns of injury. You have to use words because they do mean things to the reader, but you have to use them, of course, correctly, with the diagnosis reached based on the imaging. So please use the words compression, burst, distraction, dislocation as mechanism of injury, and having identified, for example, as in Tim's fantastic case, that the spine is fused, they need to identify that that is the setting where the injury has taken place. We need to very clearly and meticulously assess the non-ossified portions of the spine, because these are the most likely to be injured if you're dealing in a pediatric age group. Based on the mechanisms that you've just seen, then please identify compression injuries as wedge fractures, burst fractures the same way, any distraction injury as chance-type fractures, and very importantly, dislocations that occur in relation to fractures. By all means, use the term chalk stick fracture if you're dealing with a fused spine, if the injury goes through the vertebral body and posterior arch. And as I said, is the growth plate that is likely to be injured in the pediatric injury, and you need to look at these areas very closely. In case you're not familiar, I'd like to start by introducing you to probably the most important part of the vertebra in assessing cases of trauma. That is the posterior vertebral line. This is a very useful line in differentiating the type of injuries, the patterns, and therefore the mechanisms that have caused those injuries. The first is the wedge fracture. You'll identify on both the plain film and the CT and then on the MR that clearly a compression injury has taken place at this vertebral level. And by looking at the posterior outline on those three imaging modalities, you will identify that there's no disruption, so you can safely call this a compression wedge fracture without any involvement of the middle or posterior columns. And it doesn't matter how many vertebrae have been injured in this compression mechanism. This is a patient who had a surfboard injury. The principles are the same. What applies to one applies to the others. They are all compression injuries without involvement posteriorly. When you first look at this radiograph, you quite rightly will diagnose compression injuries at those two vertebral levels. However, when you then look at the L5 level, the first thing you notice is that you cannot see the posterior outline at all. However, you do know that the posterior height is reduced. So even though you cannot see the posterior outline, you know that this is different from a wedge fracture. It's something else. And if you look at the coned view, you now can identify the posterior outline of the retropulse portion of the vertebra that's gone into the canal. So loss of height anteriorly with loss of height posteriorly with a loss of the posterior outline can only mean one thing. And that one thing is a burst fracture. So in MR, you can identify the compression injuries you're already familiar with and how it differs on the burst type of fracture. Now, in a burst fracture, what you in essence are saying is that the compression injury has resulted in fragments of bone potentially radiating in 360-degree radiation. So you can see them in the sagittal plane posteriorly and anteriorly, and in the axial plane, as I said, in a 360-degree configuration. And usually there's a large piece of the vertebral body that is placed between the two pedicles at that level. On a radiograph, you can easily identify, once again, the posterior vertebral outline that's been disrupted, but also shortened. That, without question, indicates a burst fracture. One of the signs on the AP radiograph that complements burst fracture is a wide space between the pedicle on the right and the left at the level of injury. And this indicates that not only have you got trauma to the vertebral body anteriorly, but there's also, in an obligate manner, trauma to the posterior arch. Not uncommonly, this is not seen on a plain film radiograph, but it's almost always seen better on a CT, where you can see fractures of the posterior arch here and here, and not uncommonly, you also see damage to the facet joints above and below the level of injury. Burst fractures are not uncommonly associated with compression of the AP diameter of the canal at that level, and also not uncommonly, they are also associated with soft tissue injury to the ligaments at the supraspinous and interspinous, as you can see at the level of injury. Quite commonly, both fractures are associated with fragments inside the canal. And there's a lot of controversy as what should be done in terms of management of these bone fragments in the acute stage. Should you remove them surgically? Why should you remove them? Do they promote spinal stenosis in future? And what I'm going to show you, which I hope will help you, is to remember that remodeling of the spinal canal takes place with time, and these bone fragments will also remodel. Here's such an example. This burst fracture, as you can see, has large repulsed pieces of bone inside the canal, reducing the AP diameter. Less than a year later, there is more room to the neural canal tissue. The dura now has more CSF than it had before because you've had remodeling of the retropulsed portion of bone. So there is no indication to remove these bone fragments to reduce the risk of spinal stenosis in the future. What about in the acute stage? Many papers have clearly identified that there is absolutely no association between the degree of narrowing that you see in the acute stage with the status of neurological deficit, let alone neurological recovery. I can tell you that this patient had no neurological deficit at the time of that CT scan. And there's a reason for this. As Punjabi and later on Punjabi and White have shown in their dynamic cadaveric assessment studies, the maximum canal compromise that takes place in a burst injury when that bone fragment goes in the canal is 85% greater than what you see on your imaging technique, whether it's a CT, MR, or plain film. This means that if you're worried that this piece of bone is compressing that neural tissue on admission, please remember, you need to multiply that by another 85% to realize that actually the maximum moment of impact and compression and injury to the cord or neural tissue occurred at the time of impact and not as seen on that hospital image. Therefore, in this institution, there is really very little surgical involvement in these patients, although they do have obviously signs of neurological damage sometimes, as you can see here with epidural blood and also a contusion and hematoma within the cord. But in our view, these are treated conservatively, and our results, even though you've got fragments of bone in the canal, are very good when you compare them with surgical operated cases. The third type of injury, which we must differentiate, is the chance type of fracture. And in this fracture, of course, the fulcrum now is different. It's not a compression injury. It is a fulcrum that's anterior to the spine, so it starts distracting posteriorly, first the ligaments, then the spinous processes, facet joints, and it moves from posterior column to middle column to anterior column. So you have a compression injury anteriorly and distraction injuries posteriorly. And there are multiple varieties of distraction. You can have purely soft tissue, you can have purely bone, and you can have a mixture of soft tissue and bone injury. If the distraction is still present when the patient comes in, so this is your last snapshot, then it's very easy for us to identify the injury because you will see a horizontal cleavage separating the two portions of the pedicles and laminae on the lateral view. And once again, you can see the split portions of the pedicles at that level. But the clue that this is definitely a distraction injury is your interspinous distance. So if you compare your interspinous distances at this level and at this level, you can see how wide that is. So this is definitely, therefore, a distraction injury. Sometimes the two halves of the pedicles are not even visualized. Sometimes you can see almost like an empty pedicle, which can cause confusion. But again, once again, the clue is the wide interspinous distance that tells you the same mechanism has taken place here. Now, what about the posterior vertebral outline and line? How does this guide you? Have a look at this case. At first glance, you think there's a compression injury to this vertebral body, and of course you are right, but it occurs anteriorly. You might conclude that this is just a wedge compression fracture. There's certainly no decrease of the posterior vertebral height here. But if you compare the height of this vertebra with the height above, you'll notice that in fact it's increased rather than the same height. That can only take place if there is a distracting force. You have a compression fracture here and a distraction fracture at this level. And this is the MR that shows you that distraction fracture here, which gives rise to the wider, i.e. Increased height to the posterior outline. And the clue, of course, that you are right in your conclusion is the distraction of the soft tissue injury posteriorly. When the fracture takes place through the pedicles, you have a gap. And it's important to think on MR that that gap is filled with something, and that's filled with blood. And the blood will give rise to different signal characteristics depending on the time. But more often than not, on the T2 weighted sequence, you see something that we've described as the sandwich sign. And it's a sandwich because it looks as if it's two pieces with some material within it. So these are the edematous edges of the broken ends of the pedicle and the blood within the space in between. On the CT, you can identify the gap, but please remember there's blood within it, which helps you in your assessment on MR. Now, when the patient comes in with a distracted state, it's easy to make the diagnosis, but please remember that these can be reduced and your last snapshot can be very similar to this post-reduction appearance that the surgeon has achieved. So MR is the clue to diagnose injury anteriorly, middle, and posteriorly as well. Fracture dislocations are very, very easy to pick up because you have displacement of one vertebra to the other. Please remember any displacement of more than 2 millimeters must be treated as a sign of dislocation. You can now also see signs of dislocation, not only because the vertebral body have translated, but also the facet joints have disrupted and all sorts of fractures can induce from that. And not uncommonly, and sadly, these patients have a large incidence of injury to the neural tissue, which can be catastrophic. Such an example in the thoracic spine showing virtually complete transection of the cord that needed surgical fixation and stabilization. So make the right diagnosis. There's displacement, there's loss of vertebral height, there's fractures separating the pedicles. So all this is without doubt fracture dislocation. And in such a situation, treatment is usually surgical. You need to stabilize anteriorly the disrupted levels, but also posteriorly to ensure stabilization with your fixation. As I indicated earlier, a reduced disc height is a sign of injury just as much as a widened disc height is, and not uncommonly this is seen in quite severe fracture dislocations, as you can see in this case. Tim very kindly introduced the subject for me, fractures in a fused spine. I'm going to show you a few examples to highlight and stress one or 2 points. The fracture in the fused spine can be through the fused disc, or it can be through the vertebral body, as in his case. The clue here is the moment you suspect that there is a fracture anteriorly, please conclude that there must be a fracture posteriorly. So even though you can't see it on a plain film radiograph, you must suspect it and do some further imaging, ideally by a CT, which will show you the fracture very easily. And in these patients, if neglected, not uncommonly, they do produce encroachment and impingement of the cord at the level of instability, which requires surgical fixation. One very important consideration that I'd like to introduce you to is this, is that if the fracture goes through a fused disc, the vertebral bodies have not actually been injured. So although there's severe trauma, as you can appreciate on the CT reconstruction here in a fused spine, the MRI will not show you any bone marrow edema simply because the vertebral bodies have not been injured. So on a T1, there is the same bone marrow pattern as the levels above and below, similarly with T2, and similarly on the SIR sequence. Very importantly, as Tim has shown us, these patients are at a great risk of epidural hematoma, and you can see this epidural hematoma extending superiorly, almost being the same size as the cord in front of it and compressing it. I talked to you about the incidence of concomitant injury in spinal injury, if you see one level, please image the whole spine. This is very important in a fused state where the incidence is even much higher. And that patient had, at that time, an asymptomatic concomitant injury to the fused cervical spine as well. The last group I'm going to address is the pediatric trauma, the immature spine. Plain radiographs are really helpful here, because what you look out for are the ossified portions of the growth plate, particularly of the vertebral bodies, inferiorly and posteriorly. Here's such a case. This is a patient who's got a portion of the ossified portion of the ring apophysis lying anterior to the vertebral outline. That's always abnormal. And just to prove it, this is a few years later showing you the growth abnormality at that level. Plain films are good at showing you this injury. CT are also good at showing you that injury, but notice how easy it is to miss it on the MR that was done at the same time. And the reason is once again very simple, because the injury has taken place to the growth part, i.e. the cartilage part, without any damage to the vertebral body. So don't expect too much signs on the MR. So it is actually deceiving rather than helpful. Pediatric injury is very common in the craniocervical junction in patients less than 10 years of age, and not uncommonly the ligaments are injured, as well as an injury, as you can see here, to the tip of the odontoid. That complex of soft tissue injury and the odontoid is very common. But of course, in a patient with neurological deficit, what you also want to see is the damage to the cord. Not uncommonly, you appreciate damage to other levels, and in this case, not so much the CO and C1, but the C1 and C2 levels have also been injured, highlighted by fluid, as you can see, and malalignment at that level. A few more examples to hopefully get you in tune with the injury of the ring apophysis. Notice that's the normal ring apophysis here and here in the vertebra above, and that's the abnormal ring apophysis, which has been sent anteriorly to the vertebral body, and that's the MR sign of that injury. Not uncommonly, there is distraction at the growth plate injury, and this can be quite catastrophic, as you can see in this patient, leaving just the inferior part of the apophysis inferiorly with severe distraction of the whole of the C2 level and soft tissues in a cranial direction. One aspect you need to be aware is that there are different elasticities of the vertebral column, which can elongate up to 2 inches without trauma, whereas the elasticity of the spinal cord and the spinal canal cannot withstand the same degree of distraction and gets injured at just a quarter of an inch disruption. So this is a very strange paradoxical situation where you have spinal cord injury without radiographic abnormality, simply because the spine has not been injured in terms of its bones and ligaments, but the cord has been injured instead. Here's such an example showing you intact osteoligamentous structures anteriorly and posteriorly, where there's clearly a distraction injury to the cord. And this more dramatic case, no cervical injury is seen to the osteoligamentous components in the cervical spine, but there's severe swelling due to damage to the cord. So in summary, I've shown you patterns of thoracolumbar injury as well as some cervical injury. You need to be familiar with the mechanisms causing compression, burst, distraction, and dislocation. And as Tim very nicely showed you, be aware that this can be the presentation by a complication in a fused spine. And please remember how to approach pediatric injury. And the 3 take-home messages to you are: go along those 3 principles, say what you see, describe each level in turn, and try and establish a pattern of injury. Thank you. That concludes my talk, which I hope means that I've finished on time.
Thank you very much, Dr. Pullicino. Thank you very much, Dr. Yu. Yes, you have been on time as always. Now there is time for questions. So as you may know, yes, all right. Now the first question comes from Michelle Meldrum. And Dr. Pullicino, is it standard to check for atlas dislocation in cervical injury radiographs?
Sorry, could you repeat that? Is
it standard to check for atlas dislocation in cervical injury radiographs?
Yes, is the answer. In any age group, but particularly, of course, in the very elderly and the very young, you need to exclude injuries of all levels. And please remember that the assessment of the cervical spine per se should always include as a routine consideration of trauma to the occipital condyles. That is denoted as CO. And you do not finish distally before you see the thoracic junction as well. If you have, just to elaborate, if you have, for example, swelling of the prevertebral soft tissues and you cannot see an injury on the cervical spine, please remember two things. One, the injury could actually be coming from the COC1 level, but you cannot see it on a plain film, or that the injury is coming from the upper thoracic spine, which is not included in your radiograph. And because the patient is nursed in the supine position, the hematoma in the prevertebral space forms by hematoma tracking from the thoracic injury upwards. So yes, as a routine, you must be vigilant and assess all levels, including C1.
Now, Dr. Pullicino, from what I can see, Dr. Sarah Jackson would like to ask a question. Please, Dr. Jackson, connect to audio and ask your question. Hello, can you hear me?
I can hear you, yes.
Yes,
I'm sorry, this is Dr. Pullicino, I'm sorry.
Yeah, I know. Dr. Jackson? Well, I cannot see the question. Judith, do you see any question? Now, you
No, at the moment, no question.
No questions. You can ask your questions. Okay, second question coming from Dr. Gavin Pillay. How long does marrow stir hyperintensity persist in vertebral body fractures?
Okay, this is a really good question. The collective understanding, and this applies to fractures in trauma as well as osteoporotic fractures, is that by 3 to 4 months, the amount of edema that you saw initially in the acute stage will reduce. In my experience, some patients, you don't have anything after 4 months. Some patients still have some edema close to the end plate. The bone marrow edema starts disappearing from the most distal part, and it goes towards the end plate that has been damaged. But as a rule, it should be disappearing quite obviously by 3 to 4 months, and in some cases, it's disappeared completely.
Okay, thank you very much. Now, question coming from Dr. Blem. If you make an incidental diagnosis of clipal fail in a kid, there may be a tether cord. In view of this difference in longitudinal elasticity between cord and bone, would you advise to do, for instance, to MRI to show or exclude tether cord so the patient is aware of increased risk in case of trauma?
Okay, so let me answer that question by applying it to the subject first, i.e. clipal file. So patients who have clipal file abnormality, and should they unfortunately have superimposed injury to the spine. Okay, let me address it in that context first. In any patient who has fused segments from whatever cause, and clipal file is one of them, when you analyze the biomechanics, not surprisingly, the load is shared by the levels above and below, because the segment of the fused spine is not capable of taking any of its share of the load. So in cases of trauma, particularly flexion and extension trauma, rather than compression, it's not uncommon that in patients who have blocked vertebrae or fused vertebrae, usually in the cervical spine, that they are more prone, definitely more prone, and I have seen quite a few examples of this in my institution, more prone to having an injury at the level above, usually, but also at the level below. So that's the first thing. In respect to your question, I think if you have a tethered cord, there is no doubt that you also have an increased incidence of neurological deficit in these patients. But to my knowledge, I'm not aware of any studies that have shown that this is related to trauma. So I think the question is designed to interrogate, do patients with Klippel-Feil have an increased incidence of spinal cord dysfunction without vertebral injury? And I'm not aware of that being increased in trauma. I'm aware of it happening without trauma, but I'm not aware as trauma being the cause of it.
Okay, thank you very much about that. Next question coming from Kostas Pikulas. Would you recommend CT after trauma in any fused spine with pain and no neurological deficit?
Yes, the answer is this. The most important thing is that if you think about it, if you are concentrating your imaging modality in a fused spine, what you're dealing with is not a simple fracture. If there is a fracture in this patient, and as Tim showed, it can be from very minor trauma, then the fracture is always unstable. So even if the patient has no neurological deficit, please remember the patient has no neurological deficit at that time. If you don't diagnose a fracture, which would be a chalk-stick fracture, i.e. a 3-column fracture, and you send that patient home, more often than not, they present with neurological deficit when a slip takes place. So at the time of the accident, where they have no neurological deficit, the spasm of the muscles will keep the two segments more or less aligned. But then when they go home, they probably put on painkillers, they start mobilizing. That is when this slip takes place. So not uncommonly, missed fractures of the thoracolumbar or cervicothoracic levels in fused spines will present later, but not with pain. More often they present with sudden acute neurological deficit. So yes is the answer. If you suspect it, a CT, not a plain film, a CT must be done.
Thank you for that. Next question coming from Dr. Vitautas Augustinavicius. How fast after trauma we can see bone marrow edema in MRI?
That's a really good question. Honestly, I don't know the answer to that. I have seen some medical legal cases, and I would say this, that within 24 hours, I definitely would expect edema to be present in the bone marrow. And when I start moving then from 24 hours to 0 hours at the moment of impact, I suppose it depends on the trauma we're talking about. Obviously, if there's a compression injury, I would expect it to be there within a few hours, definitely. But it depends on the trauma. But certainly by 24 hours, within 24 hours, I'd expect all bony trauma, wherever that is in the body, to have evidence of edema. But the issue is that you can have, I believe, trauma to bone, which may not be readily appreciated on your routine sequences if you do it too quickly.
Thank you again for that. Now there is a next question coming in. This is from Dr. Ahmed Hazem Darwin. Thank you very much for the nice lecture. Thank you for the nice lecture. Thank you for being here tonight, Dr. Hazem. Now the next question comes from Jorn Jobge. Real case. 8-year-old with playground injury, no further detailed information about mechanism, no medical history. Now, this year-old child shows an L1 severe wedge fracture within quotation marks vertebra plana. The spinal bone structure appears overall loosened on CR. What are your differential diagnoses?
Okay, so let me just make sure I understood it. So you have an 8-year-old, eight, isn't it? 8-year-old.
8-year-old playground injury.
Right.
L1 severe wedge fracture, vertebra plana.
Okay, right. So obviously the first alarm bell there is that it is unexpected to have a vertebra plana as a sign of injury in the playground without any underlying bone disease. I have to say that it can happen. I've only seen 1 or 2 cases. It's very unusual to see it. So the most important thing, I think, is to think of some underlying cause of weakening in the bone. Now, I think you said the vertebra is loosened as well. Is that correct?
The spinal bone structure appears overall loosened on the
right.
radiograph. Yes.
That's it. Absolutely right. So that would certainly, as I indicated, make me suspicious that we are dealing with an unexpected appearance after trauma, which would suggest that there is some bone weakness. And obviously, if there is universal osteopenia, you must exclude conditions such as osteogenesis imperfecta, type 4, for example, which can present like this, but also acute marrow disease. Acute myeloproliferative disorders can also have that appearance. It would be unusual to have that degree of lucency in instances where vertebra plana, of course, the most common diagnosis would be Langerhans cell histiocytosis, but it's something perhaps worth considering. Dietary deficiency can give rise to that appearance with diminished bone density elsewhere and a severe fracture. So in essence, yes, the answer is look for an underlying cause. The appearances are not typical of a purely traumatic fracture.
Okay, thank you once more for that. Now, thank you very much. Wonderful from Dr. Jobke. Any more questions, please? Any more questions? So I see no more questions coming in. Judith, do you have any other? Do you see any more questions?
No, also from my side, no other questions arising.
No other questions arising. So in that case, I would like to say thank you to Dr. Pullicino. I would like to say thank you to Dr. Wu. I would like to say thank you to all lecturers who participated and made a success of the webinars this last season. I would like to say thank you to Dr. Miro Dadridsen and to Dr. Danube Delili, who have been the team for the ESSR webinars. Last but not least, say thank you to, well, of course, say thank you to the ESSR staff, and last but not least, saying thank you to all attendees. And we would like to remind of next season of webinars, and we would like to invite you all to ESSR in Lisbon. ESSR this year starts June 28th, first Congress Day, Friday. So I hope I see you all there. Thank you.
Thank you. Bye-bye.
Goodbye, Judith. Thank you.
Bye-bye.